nursing home, whether it may be orthopedic or any nursing home, we are a team of doctors. We go there, we fight, we stand with the doctor and fight with the people. This will enable us to keep our profession focused on the welfare of our patients and also withstand the assault on us by the society. OSA and TOSA has been kind enough, and always my orthopedic fraternity has been supportive to me to be successfully be the secretary and president of this association. This is some of the photos from the TOSACON 2018 where we enjoyed a lot. The doctor-to-doctor relation, I sometimes wonder if we could learn a lesson from the legal profession, wherein during a case argument, lawyers aggressively attack each other. But as soon as the court case is over, they maintain a degree of professional respect towards one another, despite the competitive nature of their profession. Let's not make rude or demeaning comments about our colleagues in public or in front of patients, or don't make any signs also. Seeing an X-ray of another surgeon, don't give any pause or anything. Rather, let's use proper forms of peer review within our professional organizations to criticize constructively when we believe that's possible, care has not been provided. And this is my bitter experience. I have come alive again. One team of goons, they tried to damage my reputation and blackmail me in 2019. They came, they're pretending as patients, six members gang, 3 ladies and 3 gents. She came to me for the problem of backache. When I was about to examine her, she shouted, and the remaining patients in my OPD room, they also came up and asked me, why are you misbehaving with her? They created a lot of galata in my hospital, and I was just cool. I was cool. I was not talking, I didn't tell anything, I was not scolding them, I was just listening to them. I thought I just knew they have come with a plan. These people, I have explained them what has happened, but they didn't believe. The patient, the husband has come, I have explained him, and 2 more people have come, I have explained them very coolly. Then they went to the police station and tried to keep a case on me, police case. And it has become viral over the social internet. They have taken a video of an argument and they have made it viral through the social media. Then one friend of mine, he has called me. This video is coming in all the groups. Do you have CC camera? Yes, and I have the CC camera. Then take out the thing and you spread it. I had this video. You can see in the Google, YouTube. This is if you type Balaji Hospital, you'll get it. Balaji Hospital, Warangal, you'll get it. I didn't touch the patient also. She made a galata. So I have taken this CC camera footage to the police station press where they were waiting for me. When I showed them this footage, everything became silent, and I have made it viral through all the groups. And what was negative to me, it has become positive. And our secretary Vijay Bhaskaranna, he has helped me a lot in this case, and the goons were taken care of. And being updated with advanced technology like CCTV in your hospital will save lives. If not for the CCTV on that day, I would not have been standing here now. And my services to the society, just like the Mahesh Babu told, ఊరిని చాలా తీసుకున్నాం, తిరిగి ఇచ్చారు, వెళ్ళకుండా లావ్ అయిపోతాం. Even though I'm doing a lot of service to people. So as I've served all these organizations, TOSA, OSA, IMA, TANA, Lions Club, Rotary Club and Vasavi Club. Just few of the photographs, TOSA activities. These are last 2012-18 in banquet night here. Atul Srivastava sir is there. This is the executive body meeting. This is the TOSACON. Prakash sir is standing there. KJ Reddy sir, VC Reddy sir, Jairam Chandra Pingle sir, Ravi Babu sir, VS Reddy sir. Seeing them gives a nostalgic moments. This is when I became IMA president. We have done a lot of work for IMA. Lot of free free health camps and education programs have been conducted. And for Lions Club, this is one appreciation from the IMA, state IMA, on the Doctor's Day last year. And we never forget Bone and Joint Day. Every Bone and Joint Day we conduct one or the other program in Warangal, like walkathons, cyclathons, BMD tests. We always celebrate IOA activities. And apart from this, I always spend my time for myself in the morning. Whatever it may be, I don't give it to my family or friends or anyone or hospital. I spend it for myself to be fit. I play shuttle badminton, and these are my awards recently. When I won 50 plus runners in Khammam tournament. This is in Warangal. Both are in Warangal and one is in Khammam. And now I am the vice president for the zone Thana. And he is my father, late Dr. P. Suryananda, who established my hospital in 1978. He is a poor man's surgeon. He used to take 150 rupees for any surgery along with the medicine, and used to give the money back to them for their work. She is my mother. I lost him in 1996 when I needed him the most, but he's still with me always. My mother, Rama Satyavati, she takes care of me still today. I love her. This is my family. I am blessed with my wife, blessed with 2 kids, and my wife Madhavilata. Dr. Venkat Surya just finished her graduation, and Venkat Arya is finished his intermediate. This is my family who supports me all the time, and this is my extended family. This is a group of 30 doctors in Warangal, and more of them, where with one call they all come to my rescue. And these are my staff. I have a staff of 110 members, which I believe they are my extended family. This is a quote I like the most in recent times. When I asked what surprised him most about humanity, the Dalai Lama answered, "Man sacrifices his health in order to make money. Then he sacrifices money to recuperate his health. And then he is so anxious about the future that he does not enjoy the present. The result being that he does not live in the present or the future. He lives as if he is never going to die, and then dies having never really lived." I like this very much. Live your life when you are alive. Take home message. The hard work can never be substituted. Hard work can never be substituted. We should always be updating ourselves and our workplace. Now always maintain doctor-patient relationship with proper counseling and empathy. Be humble always with the patient, with the staff, with everyone. Professional jousting should be avoided at any cost. Always love your colleague, and always maintain healthy relation with the professional colleagues, police, politicians, press, media, and district administration. Thank you.
Thank you, Dr. Sudhir. You are very hardworking, honesty, and sincere person among our members, and you are a good leader among our association also. We have learned a lot of things in the association. Thank you so much.
Now I request Dr. V. Prasad Reddy sir and President TOSA and Dr. Vijay Bhaskar sir to come on the dais.
Sorry sir, it is.
Dr. PNVSC Prasad sir, President TOSA, and Dr. Vijay Bhaskar sir, Secretary TOSA.
Please spell Dr. Prasad sir name initial as correctly. PNVSC.
PNVSC Prasad sir.
Much of practice I learned it.
I welcome Dr. Naresh Shetty sir onto the dais.
request Dr. Ramkumar Reddy Srinivas Reddy sir from Hyderabad and Dr. Veda Prakash sir to come on the dais as the chairperson for the session.
First will be Mysteries of the Missed and Mistreated Hips by Taral Nagda.
Means I get to talk for 3 minutes now. The whole idea of this talk is you have to detect things in time. Then there are no complications. And this is true about this session and also about DBH. If you pick up things in time, then you are at ease. And that's what is going to happen. So this is a story, we'll start with a small story of a firstborn female child and has right hip flip. And as it would happen, we were all studied in books that this child was advised an ultrasound, and that ultrasound showed that there was no hip dislocation. No orthopedic opinion was taken from the pediatrician, and because pediatrician had read in Nelson's book that double diaper is a treatment, they treated the child with double diaper. So that was the first mistake. Okay. Then at 7 months, it was shown to an orthopedic surgeon. And the orthopedic surgeon decided to treat it in a Paulic harness because he had read in the postgraduate orthopedic textbook that treatment of DBH at young age is Paulic harness. We missed that this child is already 7 months age and Paulic harness now will not work. So that was the second mistake which happened to this child. Finally, he went to a pediatric orthopedic surgeon, and pediatric orthopedic surgeon, having learned from his boss, treated this child with a close reduction and a K-wire fixation. Why K-wire fixation? Because he thought that the hip is not stable. Let me make the hip stable by putting a K-wire. So that was the third mistake which happened with the child. This hip stayed on, reduced, but what happened is, over a period of time, this hip started subluxating. There is acetabular dysplasia. There is coxa valga, a rotational problem, and this is a hip which will not last a lifetime. The whole meaning of treatment of DBH is that the hip which you treat at 6 month age or 3 years age or 8 year age should last a lifetime. And to achieve this, we have to do something. So I just want to ask the audience who is there, front benchers as well as back benchers, that how do you treat this? Those who feel that this should be treated even if there are no symptoms in a 5-year-old age, please raise your hands. Just raise your hands. Even chairpersons can raise your hands. Those who feel that it need not be treated now and can be left alone and you can observe and see what's happening, just raise your hands. Okay? So if you don't do anything, again you will be doing a mistake here. You need to treat asymptomatic acetabular dysplasia or femoral dysplasia need to be treated by 5 years age, and that is what was done. This child was treated by a femoral osteotomy and an acetabular procedure, and over a period of time this child has done well. So with this case, we want to learn what you should be doing to treat a case of DDH well, what not to miss and how to treat it well. I have just few minutes to treat this and I'm going to go very rapidly through all the protocols in a very short note fashion. Okay, so DDH, how do you treat DDH? If you ask a resident, the answer is very simple. Whatever is dislocated, you have to reduce it. It's a very simple rate. Dislocate hai, andar dal do. But the recipe to do it correctly is known as C3H2. This is no medicine, this is no homeopathy treatment, but this is a formula. C is for reduction, should be concentric, congruent and fully covered, and it should be stable and safe. Your procedure should be stable and it should be safe so that there is no AVN by that procedure. So whatever age you treat, this should be applied. So if you have a 15-day-old child who is referred to you with inability to abduct the hips, the history is important. So this was a firstborn female child. No one else in the family had this issue, breech delivery. So you already have 4 risk factors for DDH. Then you look at the face, the neck, the knee and the foot to know if there are any additional deformities which point to DDH. One should look at the folds, and these are not thigh folds. One should look at the inguinal folds because they can diagnose a unilateral or a bilateral DDH. So if inguinal folds normally go beyond the anal opening, no DDH. If one side goes short of anal opening, then one side DDH. But if both sides short stop of anal opening, then it is bilateral DDH. So in this child, the inguinal folds were deep enough bilaterally, and it is indicative of bilateral DDH. Ortolani's test by a pediatrician This is how you do it. It is a hip which is outside, and with this maneuver you are putting it inside. So stabilize the pelvis and very gently you try to put it inside, and you feel the clunk. You don't hear a click, you feel the clunk of entry, and that is autonomous test. It indicates that hip was dislocated. Now with this maneuver you are reducing it. Barlow was autonomous student, and always students are smarter than the teacher. So what Barlow did is he tried to do provocative maneuver where a dislocatable hip you would dislocate. So once you do Barlow's test, don't forget to do autonomous test, otherwise that poor hip will remain outside. So these are the two tests you do, and look at the limb length discrepancy. Ultrasound, according to the literature and Western literature, is a gold standard, and there are dynamic and static varieties. So positive clinical test and a risk factor, these are indications for ultrasound. But as I told you in the first case, it's very, very difficult to get a reliable person to do ultrasound and a reliable report. And I feel for India, more than ultrasound, X-rays will work. Especially if you are doubting DDH, an X-ray taken at 4 months age will work. And what do you see on X-ray? You apply IHDI classifications. You draw these lines, two vertical lines, a horizontal H line, and a line at 45 degrees. These are the lines you draw, and you get 4 quadrants. So here, you don't even have to look at the femoral head. You just draw the middle of the metaphysis. And middle of the metaphysis, depending on where it's situated, the hip can be type 1, 2, 3, and 4. Type 1 is normal, 2, 3, and 4 are progressive dislocations of the hip joint, and this is IHDI's classification, which everyone should know about. So this, having done this, what is the treatment? At children below 6 months age, the treatment is the polyc harness. It's available on Amazon now. So no one should say that it's not available in my city. Within 24 hours in your city, you can get a polyc harness through Amazon, and this is possible to get it. And this is the polyc harness. You should learn how to apply it. This is more difficult. How it works is every time a child kicks, it guides hip into flexion and abduction, and not only stabilizes but also reduces the hip joint. So, I think a separate lecture on how to manage with polyc harness is warranted. You should not use this in stiff hips, for example, arthrogrypotic hips with muscle imbalance, and for example, MMC and ligament laxity, for example, post-septic hips. The second child is now older child, 9-month-old child with limb length discrepancy and with limitation of abduction. You can now note that center 9 is disrupted, and this is IHDI 3. And this at 9 months should be treated by a close reduction. So we treated this without traction, but with close reduction under anesthesia, doing an arthrogram and spica in human position, which is very, very important. Okay? So traction is gone out of favor, but arthrogram is in. And this is what you need to do, an arthrogram through a medial approach below the adductor tendon, going towards the femoral head. And I use Omnipack as a dye, 50% diluted, not urographing, because urographing gets washed away. Omnipack is something which stays, and what you look for is a medial joint pooling. So even if hip joint looks reduced, but if medial pooling of the dye is more than 4 millimeter, you should abandon the procedure and do an open reduction. If medial pooling of dye is less than 2 millimeter, it is helpful. You give a spica in a human position with Ramsay safe zone, and then it's important that you confirm the reduction. I generally do a single slice MRI to confirm the reduction, that you are actually hip the joint is in after putting the spica. Maintain this reduction in a brace like this for at least 3 months. So spica for 2 months, brace for 3 months, that is what is the protocol, and follow up the child. Because this is a child, at 2 years you are happy, the hip is in. When this child becomes 10-year-old, 12-year-old, suddenly you start seeing acetabular dysplasias. That is the disadvantage of having grey hair and getting older and more senior, that you start seeing failures of your own successful initial procedures. So this was a national level athletic champion, started having pain in the hip joint. And that's why they came to me at age of 11 years, back to me again. And that is the time we had to do a femoral osteotomy, greater prognathoric transfer, and a GANS procedure to again get her back into active sports. Okay? So 3-year-old child, again, this is a unilateral BDH, and here a close reduction will not work. We need to do more. So there are more issues: obstruction to reduction, shallow acetabulum, antevertex femur, and tight soft tissues. And that's why what we need to do is a good open reduction through anterior approach, acetabuloplasty, varus and derotation osteotomy, more of derotation and less of varus, and lastly important to do femoral shortening, because otherwise your hip will develop avascular necrosis. So that is how through an anterior approach open reduction is done, and that is what you see at end of surgery, a stable concentric reduction with a femoral shortening, and after the implant removal the hip is still in. Late presenting cases are a big question mark in our country. So 8-year-old child, how many of you want to treat this? Okay, how many of you want to treat a unilateral DDH in an 8-year-old child? Just raise your hand. How many of you feel that it should not be treated and very dangerous? You please raise your hands. So the literature says that it should be treated, a unilateral DDH in an 8-year-old child, but it is more difficult. You need to do a lot of shortening in these cases. You need to do a very good acetabulostomy, and in AP view you will still have hip unstable at end of your surgery, and you need to protect this hip. These are the only hips I would put a wire to prevent the post-operative dislocations in the spica, and a prolonged spica 3 to 4 months, and then mobilize, and it takes at least a year to get that range of movement. So these children can do well. 12-year-old child, this girl is from Hyderabad, completely flattened out acetabulum, acetabular dysplasia. This is what happens if you don't pick up in time, and this child underwent what is known as a capsular interposition arthroplasty. So you do a trochanteric osteotomy, ream your acetabulum like you are doing THR, and then put this capsule around the head of the femur and put it back into the hip joint with a femoral osteotomy. And this patient ultimately did well. She is walking. This procedure has stayed on well for 8 years now. Okay? So this is a summary of doing the DDH right way, but if you have to give it in 2 lines, I would say that perfect reduction must be obtained for a normal hip, but not every perfect reduction results in a normal hip. So I will end with that. Thank you very much.
This is a short point presentation. What not to do in CTV. Treatment. As we know, there are various parts of CTV management. One is the reduction, management, what not to do. Here, the video. Here, in the first phase of the clubfoot management, the manipulation is the you should not pronate the great toe. If you pronate the great toe, you will get a cavus will be increased. So you should always supinate the great toe as the first step before you do the reduction. So when you're doing this adduction, with your pressure putting in supination over the great toe, the fulcrum should not be on the calcaneocuboid joint. If you do all the manipulation with your fulcrum and the calcaneocuboid joint, you get a spurious correction, because the whole movement is happening at the intertarsal joints, but not at the subtalar joint. While you are updating the foot, make sure that you don't hold the leg at the ankle or above, because this will prevent the calcaneum from moving under the subtalar joint. So here what is happening is the whole of this calcaneopedis block is getting blocked. Only the forefoot is moving. So when you're doing the manipulation, you should get full abduction of the foot, a minimum of 50 degrees before you go and do the next step. Once we get the good abduction, then only you should try for the dorsiflexion. Otherwise you get a rocker bottom foot. See, when you do this abduction, we get a dorsiflexion of the foot at the subtalar joint, and much more you do a tenotomy at the tenotomy of the talus. You get the rest of the
dorsiflexion at the tibiotalar joint. So once we do this manipulation, while you are applying the plaster, never do the plaster all alone. We need a team of people to do that. Somebody to palpate the patient, somebody to hold the reduction, and someone else to put the plaster. So whole team should be participating, and while the plaster is being held, the person should hold the plaster in the correct position before the cast is being applied by the cast applicator. So once this cast is applied, as we know, we keep changing the plasters between 5 to 10 days. Make sure the gap between the plaster removal and reapplication should not be more than 2 hours. Some people remove at the home on a previous night and come back, and this sort of things will we put 2 steps forward and 1 step backward. The plaster should never be below knee cast because it will prevent, we can't have a good control on the abduction of the foot, and also we have a problem in slippage of the plasters. So when you apply the plaster, make sure that you don't put too much of padding, which will cause the slipping of the plasters. And when you are applying the plaster, one small trick is you apply tincture benzoin on the leg, and then you apply single roll of plaster of cast, so that they will have a good fit and it won't slip. And don't put too much of pressure while you are applying this plaster. When you have too much of pressure applying, then you get the source, pressure source at a different regions. If sometimes they are associated with some neuromuscular problems, you may have a ulcers up above as well. So whenever you are putting or manipulating that, make sure that you keep changing your figures so that the pressure is not constant. So once we finish the plaster application, we get about 50 degrees of abduction. Then we go to the next step of stenotomy. And please remember, it is stenotomy, it is not endoacheal lengthening. And it is usually done with a local anesthetic. And please don't inject too much of local anesthetic. You may miss the tendon surface markings. This is a surface marking of tendon. Some people, they do tenotomy and then they inject the local anesthetic there. And never perform the tenotomy very low. You may injure the cartilaginous part of the calcaneum. And it should be always a tenotomy, not a partial lengthening where you will not achieve a good dorsiflexion as you see in this particular child. It is not a good dorsiflexion. You see a rocker bottom. So once we complete the tenotomies, then we go into the use of a foot abduction bar. For the parents,
Welcome everyone. I am Dr. Anil. I am a pediatric officer from Hyderabad. Thank you for the opportunity. So today I thought we will present it in a different way. It's a very common topic of osteomyelitis, and many people are really confused what to do. So I have these events go like a Batman and a Robin story, like a comic book. So this is the adventures of Batman and Robin in the land of what not to do in osteoarticular infections. So a 9-year-old boy came with swelling and pain in the non-weight bearing of the right foot and on of fevers in 7 days and trivial injuries in 10 days ago, and diagnosed a soft tissue injury. Robin feels I got it right. But the problem is clinically the baby doesn't improve at all. Then what happens, next also it's just a soft tissue swelling. So next there is high index of suspicion and still nothing goes good. And now he is losing it, the Robin is losing it. So next what he does, there is only one option: to summon Batman. So next the Batman comes into action and he examines the case. Why am I summoned? So he was shown the case. And then he takes an MRI and there is a osteomyelitis focus and there is a huge abscess in the foot. So once we try debriding it, what happens? There is lots of pus coming out of the wound. So we debride it, and that's how Batman is trying to escape. And we debride it, and we are very happy with the debridement and all. The baby is doing well. But 3 months post of what happens, he comes back with chronic osteomyelitis. This is all because of late diagnosis and early antibiotics. And one thing you should remember that he was always culture negative. Always, even if the bone piece sent for cultural sensitivity also, it was negative. So with that, we went with all guns blazing down. So what we did with vesicostectomy and put antibiotic coated stimulant beads. With that, that's what we were applying. And then 3 months post-op, the baby is doing really well with all infection settled, but has a residual deformity. So next, Batman feels no, Robin has to learn a lot. There's a lot to learn. So let's start our journey. We fly out to the land of what not to do in osteoarticular infections. So here we have arrived, and once they arrive there, they are met by the supervillains of osteomyelitis and septic arthritis, that is clinical presentation, next causative organisms, and laboratory markers. Next, the imaging diagnostics of osteomyelitis septic arthritis. Next, antibiotic therapy, and finally the surgical interventions. So Batman comes and asks Robin, tell me what you really know about all this. So this is where the things start, like what you have to not do in osteoarticular infections. So Robin says clinical presentation similar in all cases. Absolutely not correct. Clinical picture depends on the age of the baby, especially a neonatal baby. Septic arthritis almost all never shows any features at all. And osteomyelitis, as the time progresses, the earlier the baby shows like non-weight bearing like that, but later on presents as systemic infections and something like cellulitis of the lower limb. Next, he thinks that a staph aureus is the most common organism in osteomyelitis. No. Osteomyelitis in less than 4 years, actually gram-negative organisms are more common, especially the most common is Klebsiella kinkii and the Streptococcus. So as you can see, the Haemophilus influenza also is losing ground because of lot of immunization programs going on. And MRSA is now considered a super bug which is gaining a lot of ground in these areas. So WBC count also, he feels it's always elevated and sensitive marker. Actually no. 2/3 of WBC counts, in 2/3 of the patients are normal. And elevated WBC depends on the age. Especially older the baby, the more the WBC is elevated. A younger baby, actually they don't have enough immunity to fight it also. So virulence of the organism, the virulence of it, especially MRSA gives a very bad picture in a very early age. And also a severe case like osteomyelitis with septic arthritis actually has more badder scenario in the initial phase itself. Next, elevated ESR are significant. Actually no, ESR only beyond 55 millimeters per hour, and the clinical picture suspecting osteomyelitis and septic arthritis is more significant. And also CRP more than 100 milligrams per liter, and osteomyelitis plus septic arthritis is a very bad prognosis in CRP situations where the treatment will be for a very long time.
Can I have the presentation, please? Warangal has a good history of temples. We have visited, Dr. Me and Dr. Rao visited few of the 1,000-pillar temple. It was really, really beautiful. And Dr. Rao has told me the science behind that, how the interlocking has been used so that no gap can be seen. More of orthopedic at that time, at that era. Okay, so we'll be talking about the angular and the rotational deformities. This is a pointer to go forward and back. Yeah, this is okay, right. So this is one of the. Okay, thank you, sir. Yeah, thank you, sir. When the parents come and they say, "Doctor साहब बच्चे का पैर तिरछा है," so we are always in a rush of so many people who are coming for the back, for spine and all other problems, and then here there will be a lot of grandparents also, and they are going to eat a lot of time in your busy OPD. So you always you are in a hurry to just prescribe the vitamin D and just send him out that everything is fine. So don't do it. You have to first reassure the parents that this is a developmental problem and this is going to settle over a period of time. So the counseling part is really important. And just don't directly prescribe the vitamin D. At least take an X-ray, whether it is really developmental or it is rickets. So you need to confirm that, right? So if you took the X-ray, for example, in this child, it was a simple physiological environment. And we know you just have a simple textbook in your OPD and you can tell them that, okay, this is going to remodel like this. So at 1, 2 and 3 years, It's a developmental problem, it is going to remodel and it is going to correct of its own. So nothing more is required. What is required? Only the counseling and 2 minutes by a senior orthopedic surgeon or the practicing orthopedic surgeon. Okay? Why I am telling you is emphasizing on the X-ray, because this is a child who was diagnosed as a simple physiological genivarum, and if you take the X-ray, right, there is a evidence of rickets. So there's just by taking a small X-ray is not going to take or waste much of your practice or time in the OPD. So take the X-ray, you give the vitamin D and the deformity is corrected, right? It is like that. So it is as simple. So spend some time in counseling. That is the message here in this type of deformities. Now this is another common deformity which is there, for which the parents again come to you. So this is opposite to genu-valgum. That is a genu-valgum, where the knees are touching and there is a gap in between the two malleoli. You have to keep on measuring this at serial interval, because whether it is really getting corrected of its own, or if it is not, then accordingly you have to move ahead. And similarly, you have to take an X-ray to see whether there is some underlying vitamin deficiency is also there, right? So this is how the deformity is corrected at 1, 2 and 3 years. You can see the deformity is very well corrected. So if it is physiological, if it is going to correct, it is going to correct of its own, right? But if the deformity is like this, does that mean that this is also going to correct? The answer is no. And it is going to require some kind of surgical intervention, particularly if the child is a little elder. We are going to do the osteotomy when we are predicting that not much growth is remaining. So in that case, it requires a osteotomy, particularly those cases where you are doubtful, like if it's severe epiphyseal metaphyseal dysplasia, when even if you do the growth modulation, it is not going to work. In that case, still osteotomy is a gold standard. And this is how the deformity is very well corrected, right? So it is very simple and very straightforward. What about the problem in a small child? If you see the genu-valgum.
Good afternoon all, and thanks to Dr. Srinivas and TOSACON people for calling me for this guest lecture. My topic is what not to do in pediatric femoral fracture. As everybody knows that this is a common algorithm for femoral short fractures. From birth to 6 months, we will manage with the Pavlik harness and strapping. From 6 months to 5 years, we can manage the spica, traction and tensioners. From 5 years, we can manage tensioners, submuscular plates, actional fixators. From 12 years onwards, we have to manage the tensioners, trochanteric, entry, IMS, submuscular plates and actional fixators. As this is a useful shot that children has a lot of remodeling potential. We can correct the varus and valgus angulation can be corrected up to 30 degrees, up to 2 years. And this is in other, after 11 years, only 5 degrees of varus will be corrected. So in children up to 5 years, we can a lot of remodeling potential, so we can manage safely conservative. This example of a child who has neonatal femur fracture, which can be managed with safely with a Pavlik harness. As Dr. Karal sir already mentioned, that Pavlik harness nowadays is easily available everywhere. So this is a safety. The position is always, we can keep the hip in 60 to 90 degrees flexion and 45 degrees subtraction and 10 degrees sectional rotation and knee 90 degrees flexion. Avoid hyperflexion of the hip and extension of the knee because it will create compartment syndrome, and always try to keep knee flexion less than 90 degrees. And sometimes in case of a baby in ICU or very lean kids, we can manage simply with a crepe bandage also. We can maintain the same position. And this is one case example that this is a neonatal fracture, birth injury. Somebody has managed, they took the baby immediately in theatre and anesthesia, they put a hip spica cast. And this is not needed, just I want to highlight this one, that this is not needed, this type of taking the baby into theatre and applying this big spica immediate after delivery is not needed. Because they have a lot of remodeling potential. This X-ray shows the 12 days post-op. The parents came with showing that again. So what happened? This one, this is going on this position. But they have a lot good remodeling potential. It's healed nicely in 12 weeks. So traction, these are things nowadays not using regular basis, but in traction, like we'll keep the hip in 90 degrees flexion and knee in full extension. This indicates the management of femur fracture, age less than 2 years and weight less than 12 kg. It's difficult to manage and nowadays not needed. And the other problem with the traction is vascular issues are so common. due to tight bandage and the position, which can be avoided by keeping the knee in 45 degrees flexion and using posterior splint at the knee. Skeletal traction is nowadays not using on regular basis, but still is has a role. This can be managed by applying a pin at the distal femur or proximal tibia. But the issues are because of the long-term traction, the growth plate injury, pin tract infection, muscle wasting, and develop pressure sources. And sometimes upper tibial traction leads to premature tibial fascial closure. And nowadays it's rarely used. And like hip spica is a common method which can use it to treat femoral fractures from 6 months to 5 years. Now, you can apply a full hip spica like this, or 1.5 hip spica, or 1990 hip spica, where the baby can sit for some time. And the problem with the spica is, if the spica is too small, sometimes we get compartment syndrome, sometimes the pressure sources. And in spica, always we need to check the serial X-ray. If the serial X-ray shows shortening more than 2 cm and angulation more than 15 degrees, then we need to change the method of treatment. Either we have to wedge the cast, or we have to give a little bit of traction, or we have to go to tensioning. The external fixate also one of the methods indicated in treating femoral fractures from 3 to 15 years. Nowadays, preferring only as a temporary fixator than a definite treatment. The problem is like we can able to correct as only varus or varus one plane correction. And the pin tract infections are quite common with external fixators, and malalignment is more common. And the chance of refracture is quite high after removal of the fixator. So nowadays it's using only as a temporary fixation than a permanent tensioners, which are widely used now. Even though all books say it's used from 5 years, but nowadays we can safely use the tensioners from 3 years to 12 years, because it's a simple, the learning curve is short, it's a simple method, and we can have a good amount of correction, and patients also they are more happy, and we can avoid some amount of shortening. And the problems with the tensioners is always like avoid bending tips, because when tension came initially, they don't bend the tips. Always if you bend the tips, it should be less than 2 mm, and because if it is more than 2 mm, it causes some amount of irritation at the scar site, and the problems wise leads to infection swelling at the scar site. And also like tensioning, don't bend the tips, and always nowadays we will cut at the ends, and so that the ends should be made with supracondylar flare, so that it will prevent the irritation. And if possible, use the end cap so that it will prevent the rotation. Using end cap prevents the rotation, which is a big problem with tense nails. So use the end cap to prevent rotation and also reduce the irritation. And also like in tense nails, when you're using tense nails, avoid using use the same size nails. If you use different nails, it's a mismatching. It might lead to a varus or valgus angulation at the fracture site. And also, like sometimes the virus will, because of instability, the virus can come out from proximal fragment.
Hello everyone. I'll be speaking on supracondylar fractures, and mostly I'll talk about what you should not do with treatment and examples. So when it comes to supracondylar, we all know that it heals anyway. So why do we want to operate then? Please start the slides. Sir? We all know the classification, I will not go into details. Gartland classification commonly used. When it comes to fracture management, it's mainly based on intact periosteum, stability, the fracture pattern, and distal hand perfusion. Last one would be the most critical point. So in X-ray assessment, we all do the standard views, but clinically we should look for swelling, open wounds, and then perfusion, which is assessed by pulses, color, warmth, capillary refill, and SpO2. And finally, neurological assessment should be done before taking the check. So what do we see here? This X-ray was sent by our resident, fall from outstretched hand on a 3-year-old boy. So never accept single views. Always take orthogonal views so that it will show the true extent or nature of the injury. Otherwise, we might lead to a different treatment and diagnosis. So this is a type 2A, stable looking type. So what do we do when we get such cases? Generally we cast them and manage it conservatively, but never ask them to come after 3 weeks. Always take weekly X-rays and monitor them, because some of them might get displaced even in cast. When you have a type 2A with gross swelling, and in such swelling, if you want to get a reduction in cast, that much amount of flexion is required with the cast, and it may further compromise the vascularity. In such cases, if you feel so, always pin them. What do we do when we get a type 3 supracondylar with a pale white hand? So these are not the surgeries to be done next day. We should never wait for them. Inform the vascular surgeon, take the child for close reduction and then reduce it appropriately. If let's say after reduction also it is still pale white, definitely there is indication for exploration and the vascular surgeon will take over and do whatever is necessary. When you find a fracture gap with a pulseless hand and neurological deficits, it's an indication of entrapment of the neurovascular bundle, and such things must be explored. What do we do when we get a pulseless hand but which is well perfused? Especially from the periphery, we get a lot of referrals. So don't refer them, don't be scared. Do a reduction, good reduction and pinning, and again observe for the circulation. If it is still pulseless and well perfused, never discharge as a daycare. Wait for 48 hours, and then if it is fine, no symptoms of compartment syndrome, you can discharge the child. How do we know whether the child is having compartment syndrome? So don't look for 5 P's which are very late signs. Look for the 3 A's, that is anxiety, apprehension and increased need of analgesia. So nowadays everybody is saying 2 lateral pin enough, 3 lateral pin enough. So don't blindly follow it. See the fracture pattern. And if you see that there is a medial obliquity, there is some comminution, probably 2 lateral pins won't be sufficient. Recognize them. Generally we pin everything in flexion. So, but the same thing if it is put distally, yeah, so it won't even hold the proximal fragment. So what do? We need a PDF pin in such cases, and that's how it is done. So when we do a medial pinning, remember always don't pin in flexion and don't do a percutaneous pinning. I always, after do lateral pins, extend the elbow a little bit, push the ulnar nerve posteriorly with the thumb, and then make a small entry point just to make sure that you are on bone and not drilling the nerve, and then you can put your pin. So again, there are other indications for medial pinning which should be, go back please. Yeah. So the medial comminution, as in the first X-ray, the middle one where is high supracondylar, you need 2 medial and lateral pins. And then when you have lateral comminution as well, because that gap will lead to valgus. So never insert K-wires in a haphazard manner wherever we like. We see first one going from front to back and medial to lateral, not enough holding the proximal fragment. The second X-ray we see 2 pins are actually acting as single pin. Always space them, at least 1/3 of the fracture distance should be covered between those 2 wires, divergent, and add a, again extra pin, lateral pin if you feel that it is still unstable. And not all fractures are extension type, sometimes they are flexion type also. So beware, the routine reduction maneuver will not help. You may need to use joystick and sometimes holocanon pills to stabilize such fractures. And remember, there is a type 4 supracondylar fracture which is multidirectional unstable. That means anterior as well as the posterior periosteum both are torn. So in such cases, the fracture will go from extension into flexion whenever you are doing the reduction. Here also again joystick maneuver and a holocanon pin will actually help for reducing the fractures. So whenever you are doing open reduction, never accept a substandard reduction. Finally you are going to get the normal alignment because you are opening it, not doing it closed. So that's the X-ray malunion, and the child is having hyperextension and restriction of flexion in this case. Again, floating elbow where we have both bones forearm with the supracondylar fracture, never just cast them, always reduce them, because otherwise compartment syndrome risk is very, very high and they must be monitored very carefully. And this we all know, whenever we get a cubitus varus, what do we say? Wait, it will remodel. We know very little distal growth is there in the distal femur, so they almost never remodel. Sagittal remodeling is far better than the coronal plane. So you plan for osteotomy when the parents are ready. Thank you.
Good afternoon, everyone. Thank you, Chairman sir and National sir for giving wonderful opportunity. Today I am going to speak about slipped capital femoral epiphysis. Quite complicated. So whenever you see a child in OPD or emergency, the child is limping history of trivial trauma, or might be complaining of groin pain or thigh pain or knee pain. It could be unilateral, bilateral. Most of the children will be obese, sometimes associated with endocrine issues or syndromic. So simple, not to miss the diagnosis, go simply getting an X-ray, pelvis with both hip joints, AP and lateral view. That will be helpful in confirming the diagnosis. So, as the incidence is less at our place when compared to Western world, basic experience is needed for this one. And in case of acute severe slip, there shouldn't be any delay. And position of fluoroscopy is more important because most of the kids are obese. And with fluoroscopy, if you check in the lateral view, it's difficult to see the femoral epiphysis clearly. So once you place the child on operation table, no manipulation should be done, and the foot should be neutral or few degrees of internal rotation. Otherwise, there will be compromise of the vascularity. So if you are planning for safe surgical dislocation, the greater trochanteric osteotomy thickness should be around maximum 1.5 centimeters, not beyond that one. And you should be careful while exploring soft tissues, especially at the level of piriformis, capsulotomy, or the gluteus medius. There is chance of vascular damage to the branches of the medial circumflex femoral artery. And once the dislocation has been done, you shouldn't forcefully reduce the epiphysis onto the femoral neck. Here, there is chance of vascular compromise. The posterior periosteal sleeve carrying the blood vessel to the femoral epiphysis will compress. So we need to go for a little bit of shortening of the femoral neck, decompressing the pressure on the posterior periosteal sleeve, then reduce it, fix it, screws. There is always controversy whether to fix it or not. You can say, if you are not going for the prophylactic pinning, have regular follow-up 3 to 4 months and have X-rays both in AP and lateral view till skeletal maturity. And there is increased incidence of early osteoarthritis, patients treated conservatively. And once you reduce the fracture epiphysis onto the femoral neck, make sure that you should pass two guide wires. The second one acts as a derotation component, and sometimes in case of severe slips, we try to difficult to pass one guide wire, so we try to pass multiple times. So in this, during this passage of multiple times, there is weakening of the bone. So there is a chance of neck and intertrochanteric fracture will be seen. And you can pass a single screw or double screw depending upon the purchase. Surface area contacting. And the adequate screw purchase should be there, minimum of 3 to 5 screw threads, and accurate screw length should be there. Sometimes there will be bigger length. This will cause impinging onto soft tissues, especially in severe slip. We try to place the screw anteriorly. And once you reduce it, you need to put few degrees of abduction and foot should be neutral. And if you are suspecting the implant in the joint, just pass a contrast to the femoral cannulator screw here. Just pass it inside. You will see that whether the screw is inside the joint or not. And immobilization has to be given for longer duration of time, mostly 8 weeks of complete bed rest, followed by third month bedside mobilization has to be started. In case of acute severe slips or chronic severe slip, there is early weight bearing causes the implant failure, or early weight bearing also. So try to have fully threaded screws which will be easier to remove later on, and never leave the implant behind when you are trying to remove the implant. Other features could be chondrolysis, avian and non-avian. This is 13 years male child, came to emergency, 92 kgs, complaining of severe left hip pain and on wheelchair, and history of severe trauma was there. And past history, when he asked, he said that he was limping for past few weeks. So it's acute and chronic slip. We have operated through anterior approach. So follow-up after 5 to 6 months, we have removed the implant, and this is 1 year follow-up. The child is doing good. Thank you.
cerebral palsy, what not to do. Be wary with your wife. Sorry, it's knife, not wife. No, it largely tells the truth that the way we are very conscious about what we tell at home, what we have to do and what not to with our wives. We should be always be careful with the knife when we deal with cerebral palsy kids. Otherwise, our condition will be like this, sitting on the same branch and cutting our own branch and having a bad fall. So as Professor Brunner has very well said, and I quote him, normal function rather than normal anatomy is the goal, and thus understanding biomechanics is the foremost step before we start treating a child with cerebral palsy. So just seeing a deformity in a child with cerebral palsy doesn't mean that we have to go in and correct those deformities. A lady here with a big heels, both the feet in equinus, doesn't mean that we have to correct those equinus. Rather, it makes them look more beautiful. But the problem comes here. When we see a child of cerebral palsy, so here this child, 15 years old, diplegic, he was a community walker before, but he underwent a tendo Achilles lengthening on the left side, which has made him a non-walker. Whereas the other side is still in equinus, but that's not the cause of worry for us. This is the cause of worry. Why this tendo Achilles lengthening or gastrosoleus complex lengthening causes problem? This is very well understood by this plantar flexion knee extension couple. When the foot is loaded on the floor, the gastrocnemius or the gastrosoleus complex as it is called prevents the forward progression of the tibia over the talus and thereby keeping the foot in neutral position. And once this occurs, the gastrocnemius part of the gastrosoleus complex works on the knee joint, bringing about the late extension of the knee joint. That is the second phase of extension. So the rectus is not the primary muscle which brings about the extension of the knee joint in the second phase, but it's the gastrocnemius complex, and thereby shifting the ground reaction forces anterior to the knee joint and thereby locking the knee, and thereby reducing the amount of energy expended for walking. But once this gastrosoleus complex, if for some reason becomes inefficient or insufficient, it might be surgical or it might be normal progression of the diplegic gait. So once it becomes insufficient, this knee stays in flexion. Once the knee stays in flexion, the whole the hamstrings now cannot work on the knee joint. So we largely speak about the plantar flexion knee extension couple, but we should also understand that once the knee is locked in extension, the hamstring becomes extensors of the hip, thereby bringing about the extension of the hip. So this we can call as knee hip coupling brought about by hamstrings. And once gastrocnemius for some reason or the hamstring for any other reason have undergone lengthening, this whole coupling is lost, thereby causing a crouch gait. So basically what happens is the hamstrings are lengthened, the lever arm of the hamstring becomes more efficient to make it a better flexors of the knee than the extensors of the hip. Thereby the extension of the hip is lost. That's why in cerebral palsy cases, tendo Achilles lengthening leads to crouch gait. Tendo Achilles lengthening surgically or through any physiotherapy method wherein they try to do dorsiflexion of the foot and leads to midfoot break. The hamstrings lengthening can be achieved by two methods, either by Eggers transfer or medial hamstring lengthening. Both the methods have their own advantages and disadvantages. Eggers transfer leads to loss of knee flexion. It increases the energy consumption